My name is Charlie Rardin. I'm a member of the Division of Urogynecology at Women and Infants Hospital and the Alpert Medical School of Brown University. This presentation is based on the publication entitled An Overactive Bladder Online Self-Management Program with Embedded Avatars, a randomized controlled trial of Efficacy, which was published in the journal Urology in March 2015 by Allen Andrade et al. Pfizer, Inc. provided funding for this study. This presentation was developed and produced with funding from Pfizer, Inc. Overactive bladder, or OAB, can significantly impact health-related quality of life and is associated with substantial personal and societal economic burden. Approaches that combine behavioral interventions and pharmacologic strategies have been demonstrated to improve symptoms and quality of life. Engaging patients in self-management for chronic conditions such as OAB can positively impact outcomes. This study was conducted to evaluate the efficacy of embedding avatars in an online OAB self-management program compared with a similar voice-only or no avatars program on OAB-related quality of life, symptoms, self-efficacy, and adherence. This was a single-site, 12-week, randomized controlled trial with a parallel group design conducted between October 2012 and July 2013. Eligible participants were women greater than or equal to 55 years, living in the community with OAB symptoms, urgency with or without urge urinary incontinence, urinary frequency, or nocturia, for at least 3 months. Women who met the eligibility criteria were randomized 1-to-1 to the intervention avatar or control group. The online program consisted of 3 multimedia self-management tutorials on OAB. The first tutorial provided information on OAB symptoms, the role of the urinary bladder, and recommendations on lifestyle changes. In addition, the first tutorial had 12 true or false questions. The second tutorial provided demonstrations on how to complete a bladder diary, urge suppression techniques, bladder training, and pelvic floor muscle exercises. 4 multiple choice and 8 true-false questions with immediate feedback were incorporated into the second tutorial. The third tutorial provided 10 multiple choice questions with immediate feedback covering the topics described in the first and second tutorials. The intervention group viewed the 2 embedded avatars in the online program, a generic coach and a peer mentor developed from the front-face view of the participant. Individuals in the control group viewed the identical self-management program without the inclusion of the avatar coach/mentors. Pre-recorded voice-only commentary was provided. Participants visited the study site on weeks 0, 1, 6, and 12. At week 0, baseline surveys were completed and collected. Women in both groups viewed part 1 of the self-management tutorial at week 1 and parts 2 and 3 at week 6. At each visit, participants handed in bladder diaries and completed outcome measures before participating in the tutorials. The OAB questionnaire, OABQ, was completed at baseline and at 1, 6, and 12 weeks. OABQ is a 33-item measure to assess the impact of OAB symptoms on health-related quality of life. OABQ includes domains of symptom bother and health-related quality of life. The primary outcome measure for this study was OABQ HRQOL. Secondary outcomes included the patient perception of bladder condition, or PPBC, at baseline, 1, 6, and 12 weeks. OAB symptoms captured via daily bladder diaries, and self-efficacy. Self-efficacy endpoints included the Likert-type Geriatric Self-Efficacy Index for Urinary Incontinence, or GSEI-UI, at baseline, 1, 6, and 12 weeks. In addition, at baseline 1, 6, and 12 weeks, participants were asked to rate their confidence in doing pelvic floor muscle exercises and their confidence in suppressing the urge on a 100mm visual analog scale, ranging from 0, not at all confident, to 10, extremely confident. 47 women were randomized, and 41 were included in the modified intent-to-treat analysis, with 22 in the intervention avatar group and 19 in the control group. The mean age was 61, and the majority of women were African American at 78%, with fewer white and Asian participants, 20% and 2% respectively. At baseline, the intervention and control groups differed significantly in the OABQ, HRQOL, and urinary urgency. There were no other baseline differences between groups. At 12 weeks, there was a statistically significant difference in OABQ-HRQOL in the control and intervention avatar groups, 79.5 versus 90.9 with a p-value of 0.02. Repeated measures analysis of variance demonstrated that from baseline, there was a 13% improvement for the control group with a mean difference of 9.2, compared with a 62% improvement, or mean difference of 34.4, from baseline in OABQ-HRQOL at 12 weeks for the intervention group, with a p-value less than 0.001. Among secondary outcomes measures, significant improvements were demonstrated for the intervention avatar group compared with the control group for urinary frequency, 6.14 versus 9.45, nighttime urination, 2.18 versus 3.57, urgency, 2.31 versus 4.45, and urge incontinence, 2.59 versus 4.71 per 24 hours, with a p-value less than 0.001 for each of these endpoints. Within-group differences for changes in these symptoms from baseline revealed 57% improvement in the urinary frequency for the intervention avatar group compared to 20% improvement for the control group. 52% improvement for the nighttime urination for the intervention group compared with 24% for the control group. 62% improvement for the urinary urgency with the intervention group versus 29% for the control group. And 50% improvement in urge incontinence compared with 5% for the intervention and control groups, respectively. There were no statistically significant between-group differences in secondary measures for PBBC, GSEI-UI, or self-efficacy to control urge or self-efficacy with the pelvic floor muscle exercises. Limitations of this study include the small sample size, single site, and predominantly African American participant population. In addition, pharmacotherapy was not monitored during the study. Any potential impact of pharmacotherapy on outcomes is not known. The small sample size limits the power to detect intervention effects on the secondary outcome measures.